that these are the goals of this evening. So we're going to touch on what is migraine, how common it is. And I think the most important piece for me with my patients is how can we actually start preparing for pregnancy, and especially in a woman who has migraine, what happens during pregnancy, I think is really important to kind of have some kind of expectation as to what should be happening during your pregnancy in terms of your headaches. What are the medications that we're using? I'm not going to specifically talk about specific medications. If there's a question, I'm happy to answer it to the best of my ability, but I just wanted to give everyone who's joining just kind of broad information about the types of medications that we can use. And then something that's personally important to me is vitamins. That's probably one of the most common questions I get, and really not all vitamins are created equal during pregnancy. So what is a migraine? I'm sure you're all well versed in what a migraine is, but I still have a lot of patients that come to me in the clinic and I have to kind of, they're questioning whether their headache is a migraine versus another type of headache disorder. And I often kind of regurgitate the criteria that us clinicians use. So that is, one-sided, but we often see that many individuals can have a one-sided or both sides of their head hurt, or it starts always on one side and and moves or spreads to the other side. And that's all within the realm of normal. We like to say that it's pulsating or throbbing, but there's lots of different types of descriptive words that people use when we see them in the clinic. So it doesn't necessarily have to be throbbing. It can have other features, but that's kind of one of the hallmark features of migraine. I think the other key pieces really with migraine is that it has to be worse with activity. You don't want to go out and run or go to the gym. It's moderate to severe, sometimes to the point where you feel like you need to go to the emergency department, you have to call in sick, or you're missing functions at work or with family. You have to have one of either nausea or vomiting, and then light and sound have to bother you. So many people say they can't handle fluorescent lighting. They couldn't watch TV during a migraine. They can hear like a pin drop if someone's in the other room. They really can't hear any noise. And then we kind of do this mental calculation based on the history you provide, is how many of, column A do you have versus how many of column B? And is there anything on the history that you've provided me that is out of the norm that makes me a little bit concerned? We call those red flags. The other thing is that only a quarter of the population actually has what we call an aura, whether that's visual, being like colors, squiggly lines, a blob in your vision. Some people get tingling around their mouth and their face or down their arm. And then very rarely will you get weakness on one side of your body. But also the other things people can get is what we call vertigo. The room is spinning, high-pitched ringing in their ears. So there's lots of symptoms that can accompany migraine specifically. And the criteria is that you have to have more than 5 of these episodes. So very randomly, some people could get a migraine and it's once in their entire life and they never go on to getting that again. That wouldn't necessarily meet the criteria that we have set out in the guidelines. And then we have a time criteria. So it has to last anywhere from 4 to 72 hours. We have lots of other headache disorders out there. And we usually break up migraine based on timing, and that kind of helps us figure out if it's migraine or another type of headache disorder that we're dealing with. So what causes a migraine? I think that's probably the number one question I get, because even after I spend a lot of time with my patients explaining what a migraine is and what it should feel like, they still ask me, well, what is wrong with me? There's nothing wrong with you. We don't really know exactly what is the spark or the ignition to a migraine. We kind of know a lot of the downstream effects, and that's really where we've kind of entered this amazing world in migraine treatment, because we're now developing targeted treatments for migraine. We do understand that it's a period of time that's inflammation in the brain, and we know that it's abnormal brain activity that affects kind of the nerve signaling throughout the brain, impacts kind of downstream effects where that releases chemicals and proteins, and the blood vessels get irritated all within the brain. And what I really like to drive home, and I think, and I hope everybody that's joining really understands, is that it's a chronic condition. And there's been a lot of stigma around migraine over the decades because we don't have a nice blood test. We don't have, a picture on an MRI. We really don't have any tools to kind of, look at besides research that we have. But in real world clinical scenarios right now, we really don't have a clear marker for migraine. And so therefore, I think that it still holds a lot of stigma. And that's why Migraine Canada and all these other groups are so important, because we need a lot more advocacy out there. But we do understand some pieces. So we do know that migraine is really a mix of genetic and inherited features as well as triggers. It's kind of a mix of both together. And anybody that comes in and sees a migraine specialist or a headache specialist rather, usually will be asked, is there anybody in your family that has migraine? Is that a mom, aunts, dad, brother, sisters? And do your kids have it? Because if you have it pretty significantly, often your offspring, one of them will most likely develop some kind of headache disorder. If they don't, that's amazing and I'm happy for them. But often it does, run down the family tree. And then we know, like many migraine sufferers will identify triggers, whether that's weather. A lot of my patients can tell me when it's going to rain, hormonal, which I've given lots of talks about perimenopause and menstrual related migraine. Hormones is such a huge trigger for many individuals out there. And then stress and various other things can be triggers. But we know that that is what we call a noxious or an irritating signal to the brain that wants it to kind of become irritated and inflamed. And that kind of sets off almost like a match or a light switch that just kind of causes downstream effects. And that's really what a migraine is. Migraine, I often, when I talk to patients, I say it's almost like a seizure, in the sense of seizures or epilepsy has stages to them. There's a warning stage, there can be a visual stage, there's the stage of migraine or seizure, and then you kind of have a hangover or an after effect. And so just like seizure, there's multiple stages. And in terms of treatment, it really helps a migraine or a headache specialist if we can identify those stages, because then we can help to work to modify the triggers, kind of catch the migraine as early as we can. And now we have new medications that actually targets the stages before the actual migraine pain starts, which is amazing. So what are the types of migraine that people can have? So when you see a headache specialist, we don't like labels, but we do in this instance. And so we'll say you have migraine with aura. And that could be, again, that's the sensory symptoms that someone can experience. So visual or sensory, the numbness and tingling. Some people can get tingling in the arm. The visual is kind of the classic, what many people get if they are going to get a migraine aura. Vestibular is another subtype where some people can get, like I said, dizziness. And then I didn't add another one, which is brainstem, which kind of has a mix of high-pitched ringing, sometimes dizziness, difficulty walking, difficulty with speech production. That can all be part of that migraine with brainstem aura category. And then you have the most common, which is migraine without aura. And then when I put chronic migraine, really the distinction between episodic migraine and chronic migraine, we really are trying to shy away from that, because in the past, it really dictated to healthcare providers what kind of treatments you were candidates for. And we usually use that terminology mainly to, again, put people in boxes, but it helps us to secure insurance coverage for some of the many medications that we are now using. And the government requires us to give you a label, and that's basically just based on frequency. So an episodic migraine sufferer can have anywhere from 8 to 15 migraines in a month, and you'd be either a low or high frequency episodic migraine sufferer. And then anybody that has 8 or more migraines or 15 or more headaches, so because not every headache is a migraine, in a month would be categorized as a chronic migraine sufferer. So it's really a lot of, verbiage that really shouldn't impact you too much, but we have to use it as healthcare providers in order to figure out what medications you would be eligible for. So the prevalence of migraine, I'm not going to bore you with statistics, but again, when I see patients, they're always, upset that they feel like they're alone or that they're the only one suffering. And I feel like every single time I talk to a patient, I remind them that there are tons of literature and studies out there that show that migraine is probably one of the most prevalent chronic diseases out there. I pulled this, statistic. So we have this publication that looks at global burden of disease, and they look at all the diseases out there in the globe. And migraine is not surprisingly second amongst the causes of disability in the world, not just in North America, all over the world. It really truly impacts 1 in 9 individuals worldwide. And shockingly, we don't have more patients flooding our office because they often do not bring up their headaches to many of their healthcare providers. It's number 1 among women under the age of 50. That is a striking number. And 21 to 28% of women of reproductive age experience migraine each year. 80% of these women will continue to have migraines at some time during their pregnancy. So that's really what stems this conversation today. So again, I talked to you a little bit about migraine triggers, and the reason I bring it up is because I'm going to try and use that in some of the later slides in terms of how we can modify things during pregnancy or when we're planning pregnancy. So weather changes, we can't change the weather, unfortunately, so that's something I can't adjust. Menses, we can try and adjust menses and the headaches around them. Stress is part of life, but we can develop strategies for that. Diet is huge. That's something that we can actively try and modify. Dehydration is low-hanging fruit, in my opinion. And changes in sleep, so difficulty falling asleep and staying asleep. Sleep apnea is something that I screen in all my patients, and then lack of exercise. So oddly enough, if you don't move a lot, we like to increase blood flow to the brain, and exercise is a great way to do that. If it's not really running because you think, oh my gosh, I have a migraine, there's no way that I want to exercise. Things like chair yoga, even just lying on the ground and stretching, Pilates, any kind of movement over time is helpful for spine health, spine lengthening and strengthening, which often many individuals with chronic migraine have a lot of chronic neck tightness and tension there. So really the meat of this topic is what are the hormone changes in pregnancy? And so for anyone that has joined me previously for other talks, I really love hormones and I love talking about them, and I love the relationship between hormones and migraine. But specifically, I see a lot of individuals who are pregnant or planning pregnancy, and often in the beginning stages of a pregnancy, headache can be quite challenging. And that's really because, I don't know if anybody can see my cursor, and I'm sorry if you can't, but there's this blue estrogen line, and it always comes back to estrogen. And so in the beginning stages of pregnancy in the first trimester, estrogen is at its lowest. And that's often when migraine or headaches in general can kind of fly out of control. And then nicely, as we slowly enter into the second trimester and then ultimately enter into the third trimester, estrogen is high, and many women feel better during this stage. What I will say as a caveat to this is that individuals that do not get better in pregnancy, and there's definitely, I'm sure, people out there that'll say, you know what, during my pregnancy, things were awful. And what I would say to that is that's often in the case of individuals where hormones weren't a huge driving factor. You didn't notice that headaches were worse around your cycle or around your menses or when you're ovulating. So just because you become pregnant does not guarantee that things are going to get better. Just like when I talked about perimenopause and this belief that as soon as you go through menopause, life gets better. I hope that for everybody, but that's unfortunately not the case for many individuals. So although estrogen is a huge piece and a driving factor of it, it isn't always a driving factor 100% for everybody. I'd also like to say that for individuals who have migraine with aura is actually driven by estrogen. And so what is the worst time probably for an individual who has migraine with aura? Probably along this curve, unfortunately, in the second and third trimester, you may be that individual that notices that, where you are getting visual aura maybe once or twice a year, you're getting it almost with near every migraine that you're getting. And that's likely because you're getting a surge of estrogen around that time. We also think that, poor progesterone gets left out a lot. We know that there's some link with progesterone. And again, with menstrually related migraine, we can use IUDs and we can use high dose progesterone pills and high dose IUDs to kind of help modulate things. but truly much of the literature surrounds estrogen, and that's kind of the hormone that we know the most about these days. So my biggest joy with my migraine patients is planning for pregnancy. I think it's such an exciting time, and many of my patients come in and they're very apprehensive, and I fully understand that many pregnancies are not planned, but if we can plan for it, that's even better. So usually I say I would love the most amount of time to prepare for pregnancy if I can. So ideally I want a year. So 12 months before we start optimizing lifestyle, we are making sure water is good, sleep is good, exercise, we're getting our protein in to a good amount, we're doing vitamins. And then if we need to do acupuncture, massage, cupping, fascial stretch, relaxation, CBT, we'll do it. I suggest anything that'll work because we want you to get as healthy mentally and physically. And that's for anything, not just for someone who has migraine, but just in general, prior to pregnancy, we want you at your best. And then 6 months before, that's really when the work happens with the medication. So we're looking at your medications that we're using, especially your over-the-counter medications, especially for those individuals that really like Advil. We have to start cutting that back. And then I would say if you don't have a headache specialist, you're going to be talking to your family doctor about the medications that you're using for migraine, because many family doctors, unless you're telling them, don't exactly know what you're doing, especially if you're treating on your own. And then if you're using any other medications, let's say for anxiety or depression, you want to make sure that you talk to your family doctor about those medications and what the plans are, if any, for changing those prior to pregnancy. And then I kind of have a few tips. So many of my patients will say, I think I have maybe one migraine in a month, or I have 2 migraines in a week, but I think there's a lot of resilience in women in general. And so we often push through because we have kids, we have a job, we have life, and you often underestimate how much medication you're using and how many headaches you're actually having. So I think that's a really nice time to really check in with yourself and say, I am having 5 headaches that are mild that I'm pushing through, or I'm having 5 headaches in a week where I'm taking Tylenol, but I don't really count that, but you should. And so I think it's a good time to check in with yourself and say, how much headache am I really having? And like I mentioned, you really want to keep track of the medications that you're using. I want individuals to tell their family doctor or their other healthcare provider if the headaches change. And what I mean by that is if you start having new visual aura or new aura symptoms, if you're developing new neurological symptoms, whether that's all of a sudden you're losing vision or getting blurred vision for some reason, you're having weakness on one side of your body, severe neck pain. And the key really in neurology in general is we don't like symptoms that come and stay. So there's only a couple entities in neurology where things come and go and resolve completely, but we do become more nervous when symptoms come and they won't go away. And then the last piece is that you always do not want to wait or stop and think about it if you have a thunderclap headache. So a thunderclap headache is literally that. It is max intensity within seconds, definitely under a minute, where you're having the worst headache that you've ever experienced and you cannot focus. And those are real neurologic emergencies and you should go to the hospital. If you typically have a migraine that peaks, within 10, 15 minutes, if it builds over time to an hour, that's kind of in keeping with a regular migraine. But anything that happens within seconds, you need to go to the emergency department, especially if you are currently pregnant. So what are the types of medications that we can use? So I spend a lot of time counseling my patients about medications. So Advil is a no, and any of its cousins are a no. So there's lots of different types of anti-inflammatory medications out there. And there's some literature that you can read where maybe you could use it in the 2nd trimester or maybe in the 3rd. But I think in order to avoid any confusion, I would say it's a hard stop unless you have clear instructions from a healthcare provider as to what anti-inflammatories you can use. For instance, there are some individuals that need to be on aspirin for other medical conditions during their pregnancy, and that is obviously okay. So what I say is avoid Advil unless otherwise stated, or avoid anti-inflammatory medications unless you have clear instructions from a healthcare provider to do so. Tylenol is good. Tylenol Ultra, the Ultra is caffeine, is great. You can use triptan medications. So we have sumatriptan and rizatriptan. Those are all medications that have been used for a long time, and we believe that they are safe to use sparingly during pregnancy. I love a good topical cream, the right compounded topical cream, and I can always answer questions about what those could be. So that could be a topical lidocaine or a topical magnesium, something with menthol. A lot of my pregnant individuals love that. I said a special nasal spray, but that's really lidocaine nasal spray is the only nasal spray that we've got that we use that is very safe in pregnancy. The Cephally device is one of my personal favorites. It's a TENS device. It's really great for individuals who have more in front of their head pain. So we call it bifrontal, around the eyes, or deep boring pain in the eyes, even for individuals that have a little bit more pain in the temples. Individuals that typically get worse pain in the back of the head, the Cephally device is not a good option. And for those of you who have private drug coverage, many of you have it in your plan where you have coverage for a TENS device, and the Cephally device actually falls under that. I have no affiliation with the Cephally device, by the way, but the Cephally device is nice because you can use it when the headache comes, but you could also use it nightly. I personally like the nightly option because it's a good way of performing a pseudo mindfulness or meditation period for yourself, and I feel like if your loved one sees you with the Cephally device, they know to steer clear and give you some space. So I think it's a nice visual for your loved ones to know to kind of leave you alone for a couple seconds. The key with all of these medications, though, is that you don't want to be using anything more than 3 times in a week. So in our minds, when a patient tells me that they're using Tylenol or anything more than 3 times in a week, that kind of triggers me to think things are not as well controlled as we want them to be. And then sometimes we have to drop down here where we're using daily medications to keep things at bay. So we really use daily medications as a headache specialist if we want to prevent a headache from coming in the first place, or if we want to reduce the intensity, dial down the intensity of the headache and reduce the frequency and the intensity at the same time. Often when we use that strategy, you end up using 1 Tylenol instead of 6. And so even though you still maybe need to use the Tylenol, you're not using as much. And your brain really loves habit and routine. And so once you start telling it that 3 days in a week it's going to get Tylenol, if you decide one day that you're not going to give it Tylenol, it's going to ask you for it by giving you a headache. So we really try and avoid that in headache medicine at all costs because it's just a really slippery slope. But really, it's again, having a conversation with your family doctor or your healthcare provider about what strategy is the best strategy for you. I will also say if you do have a headache specialist, we can often do things like nerve blocks, which are procedures where we kind of numb the entire head, and that kind of provides often weeks at a time reduction in pain intensity where you don't feel like you need to use daily medication as much. So that is often open to many individuals that are pregnant. So my favorite topic is that not all vitamins are created equal. I really like to have an in-depth conversation with individuals who are planning pregnancy or who are currently pregnant about what nutraceuticals that they're using. So there's various literature about things, but I would say hard and fast rule is that a pregnancy vitamin is safe, and there's never a problem with that. If you are someone who wants to add on extra vitamins, vitamin D is never a bad idea, but we know that there can be toxic amounts, so we're not using 5,000-6,000 international units a day. That would be too much unless you're severely deficient, and that's been identified. The other thing is I love magnesium citrate and threonate in individuals who are not pregnant, but we know that we cannot max out on magnesium. So there is some literature out there that high dose chronic magnesium use can actually lead to bone malformation issues in baby, which is obviously a no-no. So your Pregvite, if you're someone who used Pregvite, has about 50 milligrams. Max that we'd want to go up to is 150 milligrams. So what I want to say is that we really want to be mindful of some of these vitamins that are packaged as migraine vitamins, as all-in-one vitamins, because, and we can get into it, and I have strong feelings about this, but Magnesium should really be saved for the evening time. B2 should be saved in the morning because we don't want increased urination. And sometimes, CoQ10, which is on the opposite end, can cause a little insomnia. So you want those in the morning, your mag at night to help you sleep. B2, Pregvite has about 3.4 milligrams. We like anywhere from 200 to 400. But again, I would stick with just the amount of B2 that's in your prenatal vitamin. There's no need to increase the supplementation. Other big questions that I often get is melatonin safe? And the answer is no, because if you think about it, you're trying to get baby to generate its own sleep-wake cycle. And by giving yourself melatonin, you're actually adjusting baby's what we call a circadian rhythm. So we don't do melatonin. We don't do things like feverfew or butterbur. And then I have a mixed feedback is what is the term I'll use from obstetricians. And if there's any obstetricians in the field out there right now, I'd love to hear your opinion. There's conflicting evidence. I have some obstetricians that love coenzyme Q10. It really depends on who you ask. And then I carry a cachet of individuals who are having fertility issues and their IVF specialist says absolutely no. So again, I think when in doubt, you really have to have a conversation. If you're really, you want to be firm on nutraceuticals and you want to take them, I would again have a conversation with your healthcare provider in terms of what could be safe and what things you should avoid. So the other thing I wanted to touch on is after baby comes. So many people think that postpartum is a protective time, and for many individuals it can. But the unfortunate part is that for many women, almost half of them who had migraine going into pregnancy, they will experience, unfortunately, a quick recurrence of headaches within the first month. There's even some data that says into 2 weeks postpartum. And I think that's multifactorial. So I think that, that's such a huge change. You've got this baby at home, you're not sleeping, you have a hard time where you are usually able to rest. You're not able to go run into a dark, quiet room and sleep. Many individuals who are breastfeeding are fearful of treating and taking medications during that time. Some women can have a different type of headache after getting an epidural, which if anybody has specific questions about, I'm happy to answer, but that's a specific type of headache that individuals can get postpartum. And then unfortunately, some women can have migraine for the first time after pregnancy, and we think that's just due to a huge hormonal shift that could just trigger something. And I have a few patients, unfortunately, where that's happened. So it kind of brings me all back to, we need more support. Unfortunately, in this day and age, through talking to a lot of primary health care providers, unless someone comes to the office and says, listen, I want to talk about my headaches, many, but some do not screen for migraine, do not screen for headaches, do not ask about migraine or headaches unless it's something that you're bringing forth. So I want to really be clear, if you get nothing from this talk, that the health of the mom is really the health of the family as a whole. It's in your own best interest to really devise a plan on how and who will help you when you have a migraine. What is the game plan in terms of who's going to help you hold baby, who's going to help you change diapers or give you a rest when you have a really bad headache. And that's, I think, a really important conversation that doesn't often get had. Doesn't often happen in individuals, and then really relying on some of these amazing websites. So Migraine Canada, the American Migraine Foundation, just asking for help. And again, talking to your family doctor about your migraine. So key takeaways, I didn't take too long, fortunately. It's a big change in your life. I don't think you don't need me to tell you that it's a huge change in your life. Really focus on lifestyle strategies. And I have a lot of patients that really buckle down on lifestyle and make a huge, they can chip away at some of the migraine days that they're experiencing. So again, hydration, getting your protein in, making sure that you're getting protein, especially in the morning if you're able to. And that's not anything crazy. That's maybe a couple nuts, some hard-boiled eggs, build in time for relaxation, making sure you're sleeping, paying attention to the headaches and whether they're changing is a key piece for me for sure. Understand that it is never a better time to have migraine. There's never been more medications, more research, more advocacy. And so there's lots of options. You don't have to feel like there's nothing available to you. There's just planning around the pregnancy. And again, ask for help. I think that is probably the most important thing that you can do to make sure that your pregnancy is the happiest and healthiest that it can possibly be.